video lecture is about thiazide diuretics. Here we will be learning the mechanism of action, pharmacological effects, therapeutic uses, adverse effects, contraindications, drug interactions of thiazide diuretics. Also, I will be talking about thiazide-like diuretics towards the end of the topic. To introduce this topic, thiazide diuretics are among the most commonly prescribed drugs, particularly in the treatment of arterial hypertension. Examples of drugs that are thiazide diuretics are chlorothiazide and hydrochlorothiazides. Examples of drugs that are thiazide-like diuretics are clothalidone, zipamide, indapamide, clopamide, and metolazone. So let's learn about the mechanism of action of thiazide diuretics. The site of action of thiazide diuretics is the distal convoluted tubule, unlike loop diuretics which act on the ascending limb of loop of Henle. The figure drawn here shows the mechanism of action of thiazide diuretics. The site of action of thiazide diuretics is the distal convoluted tubule. The drug is secreted into the tubular lumen and acts on the luminal side of the tubular epithelial cell. So the thiazide diuretic inhibits the sodium chloride co-transporter that transports sodium and chloride from the lumen into the epithelial cell and causes absorption of sodium and chloride into the interstitium. So by inhibiting the sodium chloride co-transporter, there is increased excretion of sodium and chloride in urine. Now the transport of sodium and chloride is an active transport process which requires energy, and this energy is derived from the sodium-potassium ATPase pump which functions at the basolateral membrane. So the sodium-potassium ATPase pump functions at the basolateral membrane, creates an electrochemical gradient that drives sodium and chloride from the tubular lumen into the epithelial cell and causes absorption of sodium and chloride. Thiazide diuretics, by inhibiting the sodium chloride co-transporter, causes increased excretion of sodium and chloride in urine. So this is about the mechanism of action of thiazide diuretics. The thiazide diuretics are moderately efficacious diuretics in contrast to loop diuretics that are high efficacy diuretics. The reason being the site of action of thiazide diuretics is the distal convoluted tubule, and 90% of the filtered sodium is reabsorbed before it reaches the distal convoluted tubule, where only 5% of the filtered sodium is reabsorbed. So the distal convoluted tubule has a poor reabsorptive capacity in contrast to the ascending limb of the loop of Henle which reabsorbs 25% of the filtered sodium. So the loop diuretics acting on the ascending limb of the loop of Henle causes greater excretion of solutes, that is sodium chloride in urine, in comparison to thiazide diuretics which act on the distal convoluted tubule, causing lesser excretion of solutes. Therefore, thiazide diuretics are moderately efficacious diuretics in comparison to furosemide diuretics that are high efficacy diuretics. Next, effect of thiazide diuretics on urinary electrolytes. Because the thiazide diuretics act by inhibiting the sodium chloride co-transporter, they cause increased excretion of sodium and chloride in urine. The enhanced delivery of sodium to the distal tubule causes increased secretion of potassium and hydrogen into the tubular lumen, causing hypokalemia and metabolic alkalosis. Unlike loop diuretics, thiazide diuretics decrease the excretion of calcium in urine. This is because there is increased passive reabsorption of calcium in the proximal tubule secondary to volume depletion and increased active absorption of calcium in the distal tubule. So due to thiazide-induced hypocalciuria, they can be employed for the treatment of kidney stones. Hypomagnesemia can occur secondary to potassium deficiency or hypokalemia and due to decreased reabsorption of magnesium and increased excretion of magnesium. Most of the thiazide diuretics have weak carbonic anhydrous inhibiting property, due to which they cause increased excretion of bicarbonate in urine. So to sum up, The thiazide diuretics cause increased excretion of sodium, chloride, potassium in urine. It can cause metabolic alkalosis. It decreases the calcium excretion in urine and can also cause hypomagnesemia. The thiazide diuretics attenuate the kidney's ability to excrete dilute urine during water diuresis. This action is similar to that of loop diuretics. So let's see the mechanism responsible for this effect. The ascending limb of the loop of Henle and the distal convoluted tubule are impermeable to water. So they do not cause water reabsorption, but they cause increased reabsorption of solutes, that is sodium and chloride, from the tubular lumen into the interstitium. So this causes increased excretion of free water in urine, causing dilution of urine. The thick ascending limb of the loop of Henle and the distal convoluted tubule form the diluting segment, which is impermeable to water but reabsorbs sodium and chloride. Both the loop diuretics and the thiazide diuretics acting on the ascending limb of the loop of Henle and the distal convoluted tubule respectively cause increased excretion of sodium and chloride in urine, thus increasing the osmolarity of urine and reducing the dilution of urine. Therefore, the thiazide diuretics and the loop diuretics impair the kidney's ability to dilute the urine. Unlike loop diuretics, the thiazide diuretics do not impair the kidney's ability to produce concentrated urine. To understand the reasons, it is important to know how urine is concentrated. The renal medulla produces concentrated urine through the generation of an osmotic gradient that extends from the corticomedullary junction to the inner medullary tip. The osmotic gradient is produced due to the reabsorption of urea from the collecting tubule and because of the reabsorption of sodium chloride from the thick ascending limb of loop of Henle. So the reabsorption of sodium chloride and urea into the medullary interstitium creates an osmotic gradient that contributes to concentration of urine. The loop diuretics and the thiazide diuretics have different sites of action. The loop diuretics act on the thick ascending limb of loop of Henle, where it inhibits the reabsorption of sodium chloride into the interstitium, thus decreasing the concentration of sodium and chloride in the interstitium and interfering with concentration of urine. But the thiazide diuretic acts on the distal convoluted tubule, which plays no role in concentrating urine. Therefore, thiazide diuretics, which act more distally, have no effect on concentration of urine by the kidney, whereas loop diuretics acting on the thick ascending limb of the loop of Henle interferes with the kidney's ability to produce concentrated urine. Next, the effect of thiazide diuretics on renal hemodynamics. The thiazide diuretics have no effect on renal blood flow. Unlike the loop diuretics that increase the renal blood flow due to increased prostaglandin synthesis that causes dilatation of renal blood vessels, increasing the renal blood flow. Also, the thiazide diuretics, with the exception of metolazone, indapamide, decrease the glomerular filtration rate due to increased intratubular pressure and due to absence of effect on the tubular-glomerular feedback mechanism. The loop diuretics, on the other hand, block tubular-glomerular feedback mechanisms, thus increasing the renal blood flow and glomerular filtration rate, and are preferred drugs in the presence of kidney disease. The thiazide diuretics act at a point more distal to the macula densa and have no effect on the tubular-glomerular feedback mechanism, and they decrease the glomerular filtration rate, and thereby they are not effective in renal insufficiency and are avoided in chronic kidney disease. So loop diuretics are preferred drugs in chronic kidney disease because they increase the renal blood flow and increase the glomerular filtration rate, whereas thiazide diuretics have no effect on renal blood flow and can decrease the glomerular filtration rate with the exception of few drugs such as metolazone, indapamide, zipamide, which are effective at GFR less than 20 ml per minute. Next, we move on to other effects of thiazide diuretics. The acute administration of thiazide diuretics causes increased excretion of uric acid in the tubules, while chronic administration causes accumulation of uric acid causing hyperuricemia, and this action is similar to that of loop diuretics. The thiazide diuretics can cause hyperglycemia and impaired glucose tolerance. This is due to inhibition of insulin release and decreased peripheral utilization of glucose. So this can cause hyperglycemia and cause precipitation of diabetes mellitus. Thiazide diuretics can also alter the lipid profile of the individual by increasing the total cholesterol and decreasing the protective lipids, that is decreasing the HDL levels in the body. So coming to the clinical uses of thiazide diuretics. The thiazide diuretics are preferred antihypertensive agent over other groups of diuretics. This is because the thiazide diuretics are equally efficacious as other classes of antihypertensive agent and have a potentiating action when combined with other antihypertensives. So they can potentiate or facilitate the action of a second antihypertensive agent when combined with thiazide diuretics. Also, the thiazide diuretics are inexpensive, long-acting, good oral absorption and can be given once daily. They are well tolerated, safe, does not require dose titration, have few contraindications and have few side effects. So these are the advantages of thiazide diuretics as an antihypertensive agent. The initial antihypertensive action of thiazide diuretics is due to its diuretic action causing excretion of sodium chloride and water in urine, leading to extracellular fluid volume contraction and a fall in blood pressure. However, tolerance develops to the diuretic response over a period of time, but the antihypertensive effect is maintained on long term. This is due to decreased responsiveness of the peripheral blood vessels to the actions of norepinephrine and angiotensin II on the blood vessels, and also direct vascular smooth muscle relaxant effect. So both the effects combined together help in reducing the blood pressure and maintaining the blood pressure on long term. Next, the thiazide diuretics are mildly effective in oedematous conditions such as congestive heart failure, liver cirrhosis, nephrotic syndrome. So in these conditions, the loop diuretics are more efficacious and preferred because they are highly potent, high efficacy diuretics and have the capacity to reduce massive edema. Therefore, loop diuretics are preferred in the treatment of oedematous conditions, but the thiazide diuretics are mildly effective in the management of these conditions. The next use is nephrolithiasis. Since the thiazide diuretics decrease the calcium excretion in urine and cause hypocalciuria, decrease the precipitation of calcium in urine, they can be employed in the treatment of kidney stones or nephrolithiasis. They can also be used in the management of nephrogenic diabetes insipidus, which is characterized by excretion of large amount of dilute urine. The thiazide diuretics decrease the kidney's ability to dilute the urine by acting on the sodium chloride transporter, causing excretion of sodium and chloride in urine, thus increasing the osmolarity of urine and decreasing the dilution of urine. So this is helpful in the management of nephrogenic diabetes insipidus. So moving on to the adverse effects of thiazide diuretics. Similar to loop diuretics, the thiazide diuretics can cause electrolyte imbalance, causing excretion of sodium and chloride in urine, causing hyponatremia, hypokalemia, hypomagnesemia. Hypokalemia and hypomagnesemia are risk factors for cardiac irregularities and are mainly problematic in elderly patients. The thiazide diuretics decrease the glucose tolerance and can cause precipitation of diabetes mellitus. They can alter the lipid profile of the individual and increase the risk for cardiovascular events. They can also cause hyperuricemia and decrease the glomerular filtration rate. Therefore, they are avoided in chronic kidney disease. With respect to drug interactions, thiazide diuretics when combined with amphotericin B increases the risk of hypokalemia. Also, it decreases the effect of probenecid when administered together because thiazide diuretics and probenecid both act on the same transporter, causing secretion of these drugs into the tubular lumen. So, thiazide diuretics competes with probenecid for the transporter and inhibits the action of probenecid. So now we shift our attention to thiazide-like diuretics that include clothalidone, indapamide, metolazone, zipamide and clopamide. Clothalidone is the longest acting thiazide-like diuretic with a duration of action of 47 hours. Since it is long acting, it is effective as an antihypertensive agent and given once daily. Indapamide has a duration of action of 30 hours and is effective at a glomerular filtration rate less than 20 ml per minute. Therefore, indapamide is preferred in kidney impairment. Metolazone also is effective at a glomerular filtration rate less than 20 ml per minute. So this is preferred as an antihypertensive agent because it is long acting and can also be used in the treatment of diuretic resistance where it is combined with furosemide because of its potentiating action. But when combined with furosemide, the fluid and electrolyte levels have to be monitored. Zipamide can cause brisk diuresis and the diuretic action can last for 12 hours. Because of vigorous diuresis, it is avoided in elderly patients. Clopamide is also structurally related to clothalidone and is preferred as an antihypertensive agent because it is long acting.
This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.